the whole person. Again, if you didn't hear my initial announcement for housekeeping, today's session will be a webinar format. Attendees will be muted, but if you could please use the Q&A function for your questions, we will do our best to include them into the discussion. And please use the Q&A, not the chat, so that we can track whether or not they've been answered. Libby, do you want to give me a hi sign? I still see people flowing in. Okay, let's get started. Hi, everyone, and welcome to our panel discussion today. This is the third of a series highlighting health information exchange and to meet the public health goals of the state. And we're just really thrilled that we are capping it off with this discussion today around how data sharing is able to support the whole person. We'll be exploring issues of social determinants of health, access to social services, and also readying for the CalAIM road rollout for Medi-Cal. Before I introduce our panel today, I just wanted to set the stage. And one of the white papers that we'll make sure that we share as part of the Connecting for Better Health, and you'll have that link in the chat session, was, I thought, a really great way to kind of frame the discussion today and how we really do need to focus on data sharing and get it right in order to meet our population health goals and be able to meet that triple aim. And again, there just doesn't seem to be enough spotlight on how we are looking at making sure that the engine is working as we try to meet our goals in the communities, regions, and the state. So I just welcome you to take a look at this. This is from the Healthcare Payment Learning Network, our Action Network. And again, we'll make sure that you have a link to the white paper. Next slide. Also really as a grounding element for our discussion today is the work that's happening at the state with DHCS and the rollout of CalAIM. And they recently published a roadmap or a data sharing roadmap that highlighted key barriers that need to be addressed, areas that we need to make sure that we have mitigation strategies as we roll out CalAIM. And I just want to call out the second barrier around statewide infrastructure for data exchange. That is why we have our coalition, Connecting for Better Health, to be able to put a spotlight on statewide infrastructure for data exchange. So again, I'm so thrilled to be able to have our panelists today who will talk about their on-the-ground experience, as well as more of a high-level takeaway of what we can do as a state to be able to better get to our goals around data exchange. I'm going to go ahead and introduce our panelists. Today, I am joined with Lisa Chan Son, and Lisa and I have known each other for so long. Lisa, I'm so glad to have you here today. We met actually in the halls up in Sacramento when we were developing the first statewide California health IT strategy. And I remember us huddling, talking about whether or not legislation would be needed to reinforce the recommendations coming out of that strategy. I sometimes kick myself that we didn't go forward with that strategy. But Lisa, so glad to have you here today and be able to share your experience around whole person care. You've been such a gift to the work that's been done over the last several years in our communities. Our next panelist is Bo Henneman. Bo is the Director of Special Projects at Anthem Blue Cross. Bo, I can't even imagine what your portfolio looks like these days, especially given the wholesale Medicaid transformation and readying for both CalAIM, but it seems like every single one of your programs that you're managing is getting some type of key change across the state, across the counties. So Bo, we're really excited that you're able to carve out some time today and share your experiences. And then we're also joined by Diane Rittenhouse, MD and MPH, who is both a researcher and a clinician. And Diane came to us because of her great work around accountable health communities and provided a toolkit for data sharing. So what are those key steps to be able to think about, how do I start and be able to make sure that I have sound data sharing policies in place to be able to meet my community goals. And Diane will share her experience there of being able to put together and what her learnings are from that toolkit. So again, thank you for joining us today. So here we are. I'm going to go ahead and hand it off to Lisa, who's going to walk us through the next 5 or 10 minutes or so of her experience with whole person care and the way forward with CalAIM. Lisa, hand it off to you.
Thank you, Timmy. And you're absolutely right. This does bring me back to, gosh, 10 years ago when we were having all those conversations around meaningful use and getting everybody connected and getting everybody connected through EHRs and the whole HIE conversation. So it really is a privilege to come back and have this conversation. Hi, everybody. Lisa Chanson. I'm the founder and CEO of Transform Health, and we are currently running the City of Sacramento's Whole Person Care Pilot. And so I'm really happy to share with you some of the experiences that we've seen in our pilot, share some of the learnings that our colleagues in other counties have learned as well, and welcome any questions that anyone has. So next slide, please. So I just wanted to start with, where are we now? What is the current state at play? And there's significant statewide variation. There's in the non-WPC counties, there are limited data exchange infrastructure, and it was all dependent on whether communities could access federal, state, local funding to really build out what their community needed to connect providers and to provide better care. Some common examples include, what's happening in the Inland Empire with the support of the local initiative plan, building out and connecting all the hospitals and FQHCs within one HIE. We've also seen this with the Beacon community, in San Diego, who was able to get the Beacon grant, and it really has, we've seen that be a game changer in that community. And of course, more recently with the efforts of Manifest. So there is, depending on your locality, which county, and the investments, there may be some limited data infrastructure. And many whole person care counties were able to leverage the whole person care funding to build intermediate steps towards health information exchange. And that was really highly dependent on the local appetite for this type of data exchange, the ability to build trust and engage providers, engage partners. And they really varied from being able to implement online shared care plan platforms. Some of us were able to implement roster management systems, which allowed us to coordinate and understand which programs individual patients were in, and even put in some alerting functions. Say if you have a patient that just got admitted into the hospital or inpatient, being able to get that alert and know that that just happened to one of the patients in your program, in your care. These are really valuable tools and were steps towards building a more robust health information exchange. And beyond that, a few of the whole person care counties, for example, Alameda, were able to move and build full HIE and make investments in social data exchange, connecting not only clinical providers, but really taking the next step to look across all of the social service needs and the social service programs within a community, within a county, and find ways to leverage and connect that data to the clinical data so that we have a complete view and picture of the entire person. Many of us are finding this to be extremely important and critical to have a full and complete understanding of a patient's challenges, their psychosocial needs, as well as what's happening to them in the community, because then we can craft a care plan and strategies to best support that patient to stabilize in the community, to address their healthcare needs as well as their social service needs, and be able to thrive where they are. Next slide. So that's the current state. And I wanted to spend a little bit of time talking about where we're going next. CalAIM is a 5+ year strategy to innovate and transform our state Medi-Cal program. And it has 3 major goals. We want to identify and manage member risks and needs using whole person care approaches and being able to address their social determinants of health. We also want to move Medi-Cal to become more consistent and be a seamless system, reducing complexity and increasing flexibility. That is really important because Medi-Cal currently varies depending on what county you're in. You've seen one program. So, being able to lift all boats, provide consistency to all Medi-Cal beneficiaries is an important goal as part of CalAIM. And of course, we all want to improve the quality outcomes and drive our delivery system so that we are creating more value-based initiatives. We're modernizing delivery systems and enacting payment reforms that really align quality goals and outcomes. And so to be able to do that, what we need to do to better serve our Medi-Cal population is really be able to address the complexity and the totality of all their needs, regardless if it's in physical health, mental health, as folks are coming out of prisons and jails, interfacing and helping them re-enter into communities requires interfacing with correctional health. And many of our most vulnerable, for example, the homeless, have engagement with local fire, police, crisis response, and all of these systems really are critical and important to be coordinating with so that we can best serve the client. And so to be able to meet all of these goals, we need infrastructure to connect all of these different historically siloed services. Next slide, please. And so this is the future state of CalAIM. There are 7 critical use cases identified by DHCS in the data exchange roadmap. We know that we need to track and know, be able to identify members, understand their needs, make assignment to the appropriate social services, or through the plans, connect them to the appropriate in lieu of services. There's care planning, and the development of the care plans goes beyond the EHRs, because when you're talking about EHRs tend to be individual provider focused. And what we're talking about with data exchange is looking beyond just the 4 walls of one provider, but connecting all the providers within a community so that they can best serve and coordinate and not duplicate services or create gaps when we're treating vulnerable populations. The development of care plans and being able to share documents and understand which provider provided what service when, and being able to close the loop on those referrals are all critical as part of serving the whole patient. And there are other critical needs as well. Public health does a lot of health needs assessments. The plans, the providers also do population health management. All of this data would allow us to better plan and better coordinate care and provide services in a real-time way to our Medicaid population, particularly those who are most vulnerable. So next slide. I wanted to give you an example of why this is so important. I mentioned that, we're currently leading the City of Sacramento's Whole Person Care Pilot, and many whole person care pilots, played a role last year in supporting and addressing COVID. In order to be able to leverage whole person care funding and services, we all had to ensure that the patients that we were serving and utilizing this funding for were enrolled in Medi-Cal and maintained that enrollment. And many of us leveraged the whole person care pilots to support the homeless populations that were being served through Project Roomkey. And, one of the most telling things, the reason why I wanted to share this anecdote from Alameda County is many of our counties really struggled with having the right data in the hands of providers during COVID and being able to identify gaps, ensure maintenance of Medi-Cal enrollment, and ensure that the homeless population that we were serving actually got the services that they need. And particularly with Project Roomkey, having that connection to Medi-Cal to pay for services was really critical, because a lot of the Project Roomkey funds were about covering the hotel stay and not necessarily the services to support the patient in that hotel room. So I wanted to share Alameda's experience because they were able to launch their social health information exchange in 2019, right before COVID hit. And it is incredible because their system creates a community-wide health record for the patients within their system. And practitioners, providers can pull up the record and be able to see this patient has these needs, these comorbidities, and we need to make sure that they're connected to medically tailored meals because they may be diabetic and in need of a special diet. They can see that maybe they've been diagnosed dually with SMI SUD, and they may need to make sure that behavioral health services are connecting back to the patient. So being able to see all of this was absolutely critical. And I had mentioned that maintenance of Medi-Cal was a critical piece for us to be able to use whole person care dollars to serve patients in Project Roomkey. I can share with you the experience in Sacramento, which was very manual. It was hard to do, and it actually created delays because we had to share data and encrypted files in more of an old-fashioned approach where we had to send it back and forth manually. And, it created some challenges. It took some extra time for us to be able to identify who had Medi-Cal, who didn't have Medi-Cal, how do we engage them and enroll them. And compared to the experience in Alameda, where they had identified over 100 guests who were not Medi-Cal enrolled and were able to leverage their health information exchange and quickly identify who didn't have Medi-Cal, who needed to be enrolled. And in 5 weeks, enrolled half of the 100+ guests who did not have Medi-Cal services so that they could receive whole person care and services and be connected to the types of services that would help them be safe during COVID. And as a result of that, one of the major 2020 outcomes that Alameda County saw through their whole person care pilot was they had no deaths due to COVID amongst people experiencing homelessness. And I'm really sad to say that's not always true and not always the case in some of the other counties that don't have this infrastructure. So there are many, many use cases. This is just one of them. But I hope this highlights how important it is to have this infrastructure that's the interconnective glue that enables providers to best serve their patients. So with that, I am going to turn it over to Bo Henneman, who's the Director of Special Programs for Anthem.
All right. Thank you, Lisa, for that good jump start. So just quickly, again, my name is Bo Henneman. I'm Director of Special Programs for Anthem. And as Timmy said, that at the beginning that kind of involves a lot right now. Under special programs, I do have statewide oversight of a lot of state mandated initiatives, as well as other programs that we've developed over the last several years to address the needs of members who have a lot of complex issues that they're dealing with, whether they're physical health, behavioral health, psychosocial needs. So things like the state's Health Homes program, which we've done in 6 counties, the Whole Person Care pilots, in which we've partnered with 9 counties on long-term services and supports, some of our SDOH related initiatives, palliative care, different things like that fall under my shop. And as Timmy also pointed out, all of that is impacted by some of the changes that are coming up in the state under CalAIM. And so my team is heavily engaged in the CalAIM implementation for Anthem. And the last thing I'll say about that is when I say statewide, we are Anthem for Medi-Cal is in 29 counties currently. We serve about 1.25, I think, million members across those 29 counties. So, it's a pretty heavy lift moving into CalAIM and looking to stand some of this stuff up. But, I wanted to spend my time here talking about a few things and really giving some examples of I think, where health HIE technology and data exchange amongst organizations has worked well, and where maybe it hasn't worked so well, but is much needed, and to illustrate why we need to keep pushing the needle forward. And I'll start really with where Lisa left off, and in talking about our partnerships with the Whole Person Care counties. So like I said, we did partner with 9 counties in Whole Person Care. In all 9 counties, there was some sort of data infrastructure development in place, but it did look completely different from county to county. I think the model that really stands out is the one that Lisa threw up on Alameda County. We are a partner with Alameda County on their Whole Person Care pilot. And the work they've been able to do to make those connections across health plans, across clinics, across community-based organizations, whether they're housing providers, food providers, across county behavioral health, to bring all of these entities to the table and find a way to integrate the data and develop this tool, which is useful across all of us, has really been a powerful piece of their Whole Person Care pilot. And they've utilized that tool. I think Lisa threw out some very good examples of, how it's been utilized and the impact it's had, especially on the homeless population and during COVID. But I think, their work in data sharing in Alameda goes well beyond that, and even starting in the early days of, having both health plans in the county feed in claims and utilization data, and then having county behavioral health and other CBOs feed data into the system, and being able to collect all this data from different places and utilize that to identify who needed engagement under the Whole Person Care pilot and what types of services they needed to be engaged in was really a powerful starting point, even before they had kind of this, community partner facing tool that we're now utilizing in the county. And so, I think that's a good example of how working through the barriers around data exchange and developing a system has made a tremendous impact. In our other 9 counties, each county has taken a slightly different approach. I think we did partner with Lisa and the Pathways team in Sacramento, and have seen a lot of good results in the data exchange that has happened there. In some counties, the data exchange build out and the technology that was built was really just to better connect different departments within the counties. I think where, sometimes they were running on different systems and not really doing enough to coordinate between, Department of Public Health, Department of Behavioral Health, and so forth. So, each county has kind of taken a different approach, and that's meant for us as a health plan that in some cases we have access to a really useful health information exchange tool like we do in Alameda. In some cases, it means that we are simply feeding data to the counties and getting some data back that we then have to incorporate into our systems. But in either case, it's been I think what Whole Person Care has done across all of our counties is really work to break down barriers. Even if it is as simple as, data feeds coming in and going out, and we're incorporating that into our system, that's something that as a health plan, we didn't have access to before. So we now have better insight in some of these other services that are being provided by the county or sometimes by community-based partners. And then, just breaking through some of the, outside of the technology piece of health information exchange, moving the needle forward on some of the discussions around the legal issues and having data sharing agreements in place with organizations that, as a health plan, we never had data sharing agreements in place with before, and getting, I think, everybody's attorneys to start thinking about data sharing and interpretations of HIPAA and other privacy rules in kind of a different light. Has been a big benefit of Whole Person Care and pushes us in the right direction, because at the end of the day, you can have, the greatest piece of technology that's available, but if you still have those legal barriers and that resistance to share the data, it doesn't work. And Whole Person Care has really driven the needle forward there. Just to give you some examples, though, of other initiatives at the health plan in which, I think we have to keep pushing the needle forward. And these are things that, I won't go through everything that my team does, because I could probably spend like 2 hours on each program talking about the data that we're doing and where the gaps are and everything else. But just to give you a couple of high level examples, I think one is our work with long-term services and supports. So long-term services and supports within a managed care environment means that we're covering long-term care in a skilled nursing facility, we're covering adult day health care, but we're also coordinating services for members flagged as high risk and potentially needing other types of community support. And that piece is a little difficult to do because we lack so much data. I think within long-term services and supports, you kind of lump some of those services in with home and community-based waivers, which are carved out of managed care, and we have no data coming in from those waiver providers, no mechanism for getting that data. There's also a lot of overlap with the county's in-home supportive services program. And while we do get some data from the state on IHSS, we don't get enough, and we don't get that full connection that we need to truly be able to sit down and work with the member and figure out, okay, well, who else is working with this member and where do we need to make connections? We kind of have to manage those services in their own little silo today. I think another example is the work we've done around health homes over the last couple of years. And if you're not familiar with health homes, this is at the end of the day, it is an intensive care management or care coordination program that's driven at the community level. So as a health plan, we work with FQHCs, we work with local mental health clinics, work with other community-based organizations to engage these members and provide this intensive level of care coordination. But that does involve addressing both the physical health, the behavioral health, and the psychosocial needs of the member. And again, you kind of run into those same barriers where, without this basic infrastructure, this data sharing infrastructure or health information technology in place, you see a lot of gaps. We're making assessments based off of information that we have, but we don't have a lot of data on some of those external services, whether it's county behavioral health data, whether it's SDOH related data, other community health type of data, which would really be useful in really understanding what the member's needs and make sure that our health homes providers are working with that member to establish goals that are really going to address those needs and really understand what other organizations they need to coordinate with. So I think, health homes has definitely been successful. I don't want to frame it up as health homes not being a successful program, but it definitely has had some gaps and could benefit from some additional data exchange. So, I think that gives you a couple of good examples. I don't want to go too much deeper right now, although I will say that, I think we'll have some opportunity to talk a little bit more about CalAIM through the course of the presentation. And CalAIM is definitely a massive shift. I think Lisa's slide, calling out the different components are are so critical, and data exchange is really going to help us improve upon some of the things that we've been doing over the last few years. And I think, help us take the next big step towards providing truly integrated care and doing that through more robust data exchange systems. So I will stop there, and I think turn it back to Timmy.
Yeah, thank you, Bo. And I'm going to send it right. Thank you. And we'll definitely make sure we hit on all those points in our Q&A. And I'm going to hand it over to Diane. There you are.
Hi, thanks so much. So I'm really thrilled to join this discussion today and hear about all of the advances and the successes that are happening. I'm a family physician and a professor at UCSF for the last 20 years, and a researcher that really lives at the intersection between research and health policy. And so a few years back, when Accountable Communities for Health were really getting started in California, and there was some money flowing to communities to invest in multi-sector community health improvement, the state of California asked me and my colleagues to put together a toolkit that would be useful to communities that were across the spectrum in terms of data sharing across sectors to improve the health in the community. And so, we heard a lot at that time that there are the San Diegos and like the Alamedas that we're hearing about today. But what about those communities that are just getting started or who are just contemplating getting started? And how do we help those communities sort of know where to begin to plug into this kind of work? So our toolkit was designed to target both ends of the spectrum, and we worked using some maturity models saying across a number of parameters, whether you could sort of see where you fit in as a community and where you needed to plug in and what your next step might be. And obviously, California is a large and diverse state, and we're hearing a sort of a theme across Lisa and Bo's presentations that a lot of these efforts to share data across sectors have happened at the level of the community or the region, and there's quite a bit of variation in expertise and experience across the state. So what we did is we dug in deep and we did literature reviews and we did key informant interviews and we talked to key stakeholders, and we did some in-person site visits to some communities way up north, down in San Diego, in the Central Valley, out along the coast, to try to figure out what are kind of common themes and how can we create a framework for folks to start thinking about these issues. So I have just one slide today. And if you could post that, it shows a very simple figure with the 7 parameters that emerged that we identified in our research, the 7 parameters of data sharing. And I'll walk you through this quickly from sort of a theoretical standpoint or sort of the ideal, and then we can move to discuss how this actually works in the real world. So first, in any effective data sharing effort, you need to identify the purpose and the goals of the effort. And that seems very simple and very simplistic, perhaps. But we found in talking to people that without a clear goal or a clear aim of exactly, and a very specific goal that was agreed on by participants and stakeholders, that things just couldn't get moving. And then once you have a clear purpose and aim, you can start thinking about the relationships and the buy-in that you need. So who do you need around the table? If that's the problem you're going to solve, so maybe it's decreasing rates of childhood asthma or decreasing rates of homelessness or opioid overdose or whatever it is that you're looking at in your community that you've decided you want to solve, who are the key stakeholders? Who are the people you need to have around the table to solve that problem? And that's different than saying, where are the data? How do you get the data? What are the technical solutions? You really need to start with problem solving, getting the right people around the table. And once you have the purpose clearly stated and you have the right people around the table, you're in a position to get some funding to start moving these ideas forward and operationalizing things. And, funding really ranges from local foundation kind of funding, maybe in-kind contributions from various partners around the table, maybe a bond measure, and even state funding, like we're talking about national foundation funding, that kind of thing. And so some of it's limited grants and some of it's actually longer investments that people can make. But once you've got the relationships and the buy-in and you know what you're trying to do and you've got the funding, then you can move towards thinking about structures and processes around governance and privacy, and putting in place those things that you need to do to protect the system and to develop the system. And then you get into what people think about as data sharing, right? Then you actually start thinking about, well, what are the data elements that are going to be exchanged or shared, and how can you build out the technical solution and expand the analytic capacity. But there are these, I just want to really point out that there are these things that need to happen. And I think we've heard that in the use cases that were discussed already on this call. But without those kind of core elements in place, it's hard to move forward. So how does this actually all work in the real world? In reality, it's an iterative process. And while you can make progress along one parameter, and that may speed progress along some of the other parameters, things really look different in different communities. And I think, why does it look different in different communities? I think it really gets back to the very basics of different communities have different priorities. They have different people involved. They have different relationships, therefore, that need to be built. They have different funding sources, but both the kinds of funding and the length of time for the funding, and sometimes the funding is tied to particular goals or aims that are different across communities. And they build governance and privacy based on that and begin to work out their data solutions and their technical solutions. Then they may have a legacy system that they're trying to build with, to work with, or they may be starting from scratch. So every community really does look very different. And this framework is not in any way a static framework. These are all moving and evolving parts. And it's very common that a particular effort might move back along to a previous stage as it incorporates new strategies or maybe brings in new partners. So it's this constant sort of back and forth iterative process around thinking about these pieces. But I think it's helpful to sort of have this in front of us and think about this as a framework for our discussion. So I'll stop there and hand it back to, I believe, Timmy.
Hi, for some reason, I'm unable to start my video, but can you all hear me? Give me a...
Yes.
Okay, great. Well, thank you so much. Oh, there I am. Thank you so much for grounding us. And also, Diane, I think it's always so great to remember that, or not only remember, to be able to have that framework as we go about the data sharing agreements in the communities, but then how do we kind of layer that and think about it in community, region, and state. And so from there, I'm actually going to just use just a very specific example of that. Lisa, how did you tackle consent? And we've saw as part of the CalAIM recommendations that there's a need for a more statewide, I'll use the term universal consent, but where and how does that happen at the community level? And what are the key pieces that need to happen all the way up to the state?
And I can share with you our experience in Sacramento and our whole person care pilot as we develop consent. We took a really broad look at both the federal rules, the state rules, and worked locally with all of our partners. And being a second round pilot, we had the benefit of learning from all the first round pilots, and we're able to leverage the good work that was done by many other communities. And one of the things we realized is we could structure our consent for the entire period of the program, which meant that we only needed to ask the consent of patients once, but make clear that it would be for the entire duration of the program. So we're not constantly going back year over year asking for those additional consents. Being clear on what the rules and parameters are and what we can and can't do was incredibly important. And by having that universal consent tying back to a data sharing agreement across all of our providers and partners, meant that everybody was operating under the same rules. And as long as the providers signed our data sharing agreement, and we had 6 health plans at the time, 2 dental managed care plans, 6 FQHC systems, 4 hospital systems, so it was, and then a broad set, about 40 CBOs, that we were organizing and bringing together. And so being able to say, here's some rules that have worked in other communities, being clear and transparent and giving everybody a seat at the table. We use a collective impact model and framework to bring everybody together so that we were operating in a transparent way, and everybody who had a seat at the table had a voice in the design of both our data sharing agreement and the consent, so that we were making sure that we understood the aspects needed from housing, from behavioral health, from our clinics and our plans and our hospital systems. And so that allowed us to create one seamless approach. And we collected all the consents in our shared online care plan. So all documentation is available through this online shared care plan, and every provider touching the patient had access to that same record and was able to share the consent, their ID. We didn't have to ask the patient multiple times for the same thing. And it just enabled the coordination, the conversations to be much more seamless. And so, one of the things I'll say is, it's incredibly important for the state, for the feds to set the rules of engagement. At the end of the day, what we see now is a recognition that data is power and control. Who controls the data controls and understands the flow of patients and flow of financing. And so, those are natural market dynamics that come up, and we do need policymakers to set the rules of the road and say, these are the things we need to do for our collective good. And so, we've had some providers that have signed our data sharing agreement, and then when it actually came time to share data, refused to share data. And that creates other challenges, because then we have to find alternative ways to get access to the data. And it makes not only managing the program hard, but at the end of the day, we're not best serving the clients, the patients themselves. So I think it's incredibly important for policymakers to understand those market dynamics that are driving different types of behavior, and set policy to support what's best for consumers and patients. And there's also been public funding to fund a number of social exchanges, or for example, under the direction and guidance of Clark Kelso, the prisons built a whole statewide prison health information exchange. But that information exchange really hasn't been connected to the exchanges that providers in the clinical space have used. And so we have to be thoughtful about connecting the investments that we've made using public dollars. And in another example I can give you is with the state.
Let me cut you off right there, because there's an email, or there's a question that came in that we should probably define consent. And the question is, when you say consent, do you mean individual authorization from the individual to share their data with other stakeholders? And I think the answer is yes, correct? Okay,
Yes,
I just wanted to make sure. And maybe we can come back on the other example. I just would really like to be able to kind of unpack a little bit the idea of participation, and where and how I think, Bo, you're on all of the multiple programs that you outlined with long-term care, as well as with home health, and then now wrapping into CalAIM. How are you thinking about getting the data you need in order to do the analytics that are required by the state to be able to accomplish the goals? I mean, where and how there must be some levers that you can pull, but what are those?
Well, I think I spend more time trying to deal with the anxiety I have over that question of how are we going to get all the data that we need to support the work that has to be done under CalAIM, because it is pretty robust. And I think that there's a lot of moving pieces to that. I think, at this point as a health plan, and not just Anthem, but other health plans, we're engaging heavily with the counties and talking about data needs and data sharing that we haven't had before. We're engaging with the state to try to figure out, how do we get additional information? And I think, this is where the question around state role versus, the local role really comes in. And Lisa kind of alluded to this, but I think, just a couple of examples, if you look at something like HMIS data, which is Homeless Management Information System data, we can either do it at a county by county approach where we're engaging each county and trying to get separate data feeds, or there could be some sort of statewide solution in which data is coming in. And it would obviously be much easier and much more efficient and standardized if you had that statewide solution. I think the prison systems, another good example, it's not starting on day one, but a core component of CalAIM is that we are better addressing the needs of individuals who are transitioning out of the local jail and the state prison system and making sure they're getting ongoing care coordination and connection to services. But today there's a big disconnect in that data, both from the prison and the county jail system, and some oftentimes even between county probation and other county services. And so there are a lot of barriers to break down. And so, I think that there's definitely a role from a statewide perspective to help us break down some of those barriers and figure out how do we get all of this data, looking at, whether that's some sort of standardized data format or a centralized health information exchange system, all the way to, going back to things like member consent and how do you get all these organizations to participate. I think the big challenge is also that, when it comes down to it, we've got all these rules that we have to follow, and everybody's attorneys interpret those rules differently, right? And that becomes very challenging where, even within one county, if you've got 10 organizations and they're all interpreting those rules to be different, it makes it difficult to get that participation and that buy-in to feed into the system. And so I think that's something that we have to work through. And then the other piece is, if you have a system and, going back to Alameda system or even, your system in Sacramento, Lisa, again, you build the tool and you get through the data sharing agreements, but then getting people committed to utilizing the system and embedding that into their day-to-day process is another challenge. And it takes time. I mean, I think the key to that is just being persistent about the messaging, giving clear examples of how this is going to make care coordination easier, how this is going to be better for the member, and slowly people start utilizing it more and more, and you start to see the impact.
I was really struck, Diane, of in your toolkit, you have a whole section, of course, around building trust. And I was struck by the notion that data sharing actually builds trust. Just being able to have that kind of exercise and building that muscle, you start building more and more trust. I don't know if you want to kind of give us a snapshot of what you learned when you looked at the community's experience.
We just heard over and over. It's interesting you asked that question because we actually had a little bit of pushback when we even included a section on trust, and because the one of the organizations that was involved with helping to fund this was saying, no, we just want to know the data. So we want to know how to share data. We want to know how to share data. Trust, okay, whatever, but we know. And when we'd go to communities and we'd say, how do you share data? They would say, well, data only moves at the speed of trust. And they would say, let me talk to you about relationships, and let me talk to you about trust, and let me talk to you about, 15 years ago, Dr. So-and-so and I and the head of, or I happen to know the guy that runs the this and that, or we had a small grant and we, got started on some smoking cessation stuff. And then when this other opportunity came up, we went together and we looked at that. So communities talk to us a lot about this issue of relationships and trust, and the fact that data sharing and data, and like you're saying, even if you can sign an agreement, if there isn't some underlying buy-in, people won't even use it. And so, it isn't a waste of time to talk about trust and to think about the importance of those kinds of relationships. And it's true that there's a lot of different things that feed into that. I think that there's a lot of we go through a lot of different obstacles and barriers to trust and ways to kind of come around them. But some people are feeling like, well, they're going to find out that we don't have perfect data, or that we don't know everything about this problem, or that we're going to lose control of something, or so there's a lot of different kinds of obstacles. And I think thinking through what all of those different obstacles can be, and really working with your partners around, how do we do something small? Maybe that's one way to approach things. And we heard this a lot: start small. And that's not always the way you want to do it. Sometimes you want to start big, and sometimes you have a pool of money and you got to start big. But a lot of these communities had really good experiences starting small, building trust, moving on to something a little bigger, bringing in some more partners, again, having another success, and really kind of working that muscle. So
Thank you. And Lisa, I saw a hand go up.
Yeah, Diane, what you're saying resonates so much with me, because that is exactly the experience we had in Sacramento. We wanted to go way beyond what we were able to build, get as close to HIE as possible. But early on, we had a lot of questions come up about that were really at the core of it about trust. We heard from some of our clinical providers and plans like, geez, like the standards in healthcare is different than on the housing side. Can we really share data with our housing providers in the same seamless way? And, hearing the concerns of the community and knowing that that trust hadn't been built yet, we had to take a step back and go, what could we do to demonstrate that this can be done in a way that is protective of not only the patient, but of the providers themselves, and use that as a mechanism to continue to build that trust. And I think we've been able to demonstrate that, there are ways to address the differences between privacy standards when we're going from clinical to social services, to think through how to build the systems and the flow of data in a way that is supportive of building that trust. But without the trust, we couldn't really do the build out that we want. And so, I'm so glad you brought that up, Diane, because I think that's a critical component that really sort of defines the box by which how fast and how quickly a community can go in terms of building and achieving its HIE goals.
So I think that that's something as a major takeaway. I think without that trust, or I guess, let me reframe that. In order to build trust, we need to continue to tell the stories. We need to continue to do panels like this. We need to continue to, really shine spotlights on where it works, so that we can, hopefully make better progress faster as we move forward.
And I think very much like in medicine, I'm a family doctor, very much like in medicine, where you're dealing with a bunch of different specialists and a bunch of different, lots of times you can kind of cut through some of this by saying, well, what's best for the patient? And I think in this case, it's interesting. Bo uses the word member, and Lisa uses the word client or consumer, and I use the word patient, and we're all trying to talk about the whole person. And, it's about bringing people together and finding common language, and really thinking about what is best for the community and what is best for the person at the center, the child who has an IEP at school and has somebody coming out to the house for social services, but nobody knows who that person is or what they're doing actually, and you ask the parent and they say through the translator, well, it's a woman who has brown hair, and and that's all about the social services that this poor kid is getting over the summer when the school is out and you can't get the access. So how do we kind of put our arms around this and say, what is best for the patient, what is best for the member of the community, and kind of get over ourselves a little bit and find ways to move forward.
That's right.
I love
and
that.
doing that translation of terms, because sometimes we use the same terms in different sectors, like case management means something completely different in the healthcare space than in the housing space. And, you know, doing that translation, creating common definitions and having the conversation that, hey, when I say this, this is what I mean. Does it mean the same thing to you, is absolutely critical to building that trust.
I am, there's another question that just came in where we only have about 5 minutes left. Maybe I'll try to get 2 questions in here, but I think it just builds on what you just said, Lisa, which is in addition to encouraging partnerships, you know, it would be helpful to standardize assessments of trusts. Is there a way for us to, you know, start there? Maybe it's terms and being able to have a standard assessment. Is that something that you're seeing as a trend, or has it been helpful? Let's see, Bo, you want to take that? I'm sure you would love to see some standardization across the board.
And standardization helps, but I think I would say standardization to a certain extent, because at the end of the day, you know, knowing that we're across the state and in 29 different counties, each county is very different, and the local needs of the people who live in that county are very different. And so you do have to have some flexibility to account for, you know, those individual local needs. But I think that, you know, in terms of you know, how do we work towards building trust and some additional standardization, you know, it really does, it does start with just bringing people together, starting to have them engage, bringing the small community-based organizations and the health plans and the community clinics and everyone in the same room and talking through all of this. And I think, Dr. Rittenhouse, you're right. And if you haven't noticed, you've been nominated for the next presidential election over here in the chat. But it's you know, that is really the starting point, and putting the member in the center. I mean, because whether it's member, patient, or anything else, you know, this is a person who has needs, and what isn't good is that, you know, we're in a system where we're not connecting the dots on the data. We don't truly understand the needs. You have one organization trying to address things over here, another organization over here trying to address something else. And that's confusing for the member, and neither organization may truly be getting to the root of the cause of what's going on with the member. And so, you know, I think if you keep that in the center, and we've seen this happen, you start to bring people together, you talk about, well, how can we work together better? And then you start thinking about standardized assessment and standardized data sharing. Like that's what's going to drive it, because Dr. Rittenhouse, you're right. I mean, it's you know, otherwise, you know, you can't have people coming at it with like their own motives and, well, this is what's going to be best for my organization, and this is what will be best for my organization. It has to be what is best to make sure that this individual is going to get there and access to the services that they need.
Well, with that, I think that is a great note to end on, is to have the patient at the center and to be able to get organizations to not only agree to how best to be able to share data, but to actually share the data. And maybe out of all this, we need a mediator of some sort. That might be something we think about. But I also want to thank our panelists. You guys are fantastic, and I'm so glad that this was recorded and it'll live on. And also want to thank our partners with CAL-IHEA, the California Institute for Health Equity in Action, and they will be also working on developing a piece that will summarize the proceedings from today. So thank you. And if you didn't see it, I think it was in the chat, we have a really great issue brief that also helped to be a primer for today's session, and that'll live on our website. One last, I guess, welcome to you if you're not part of the coalition. We really want our tent to be as wide as possible and represent diverse groups, and really have healthy conversations around the need for statewide data exchange. So please, if you would like, join us. You can hit the Join Us tab on our website, or just go ahead and email us. You have our email in the chat. We meet on a regular basis, usually about 2 times a month, sometimes more in the legislative session. And we have great programming. And again, thank you for making this series of health information exchange, meeting our public health needs, a success. We really appreciate you today. Thank you, and have a terrific day, everyone. Thank you.